Hello everyone, this is Dr. Mohib and today we will be discussing about disorder of appendages, that is the nails and the hair. Alright, so first we will be taking about the hair part, and in the hair first we will start about the anatomy, we will see about the hair cycles, and then we will go up to what are the types of hair losses which are there, right? Some types of alopecia we will be discussing, and what can we do to keep the hairline in place, right? The major question, I guess, for everybody who's aging, so we definitely want to have a good hairline, we want to have good density of the hair. So what can we do to maintain this hair, the density of the hair, what can we do, what not we should do, moreover than what not we should do, we should know it, right? So some tips and tricks and a lot of theory will be coming up your way. Alright, so let us begin our lecture. Okay, so first of all we have the anatomy of hair. Okay, so it's always anatomy, right, that we have to start with. Okay, fine. So let's start with the anatomy of hair follicle. So definitely we all know this one muscle. Yes, so the erector pili muscle which is there, yes, over here, and there are different parts of the hair, right, that we need to know. Yes, definitely we know the layers of the skin is fine. Now we are going on to the hair follicle. Yes, so this is the whole hair follicle, as you can see in the image. Okay, but before that, starting discussing about this, I want you to, if you remember these two landmark structures, then it is easy to differentiate the part of hair. If you know these landmark structures, it will be very easy for me to teach you the life cycle of a hair. As we go further, if we know just this one point, so it is very easy to actually understand that, okay fine, this is happening from there, we need to just keep these things in mind. Alright, so all said and done, the two things over here, that is, so first of all we have the hair bulge. Alright, and the second thing that I want you to know, this is the sebaceous gland, right? Sebaceous duct. Now we know these two things. Okay, so the hair bulge divides the hair into upper segment and lower segment. Okay, and the sebaceous gland which is there, it divides the hair into isthmus and infundibulum, as you can see over here, right here. So we have hair bulge over here. Okay, so this is the part which is the hair bulge. Okay, so what is the hair bulge? Okay, so this muscle which you see, that is the erector pili muscle. Yes, so where it attaches to the hair follicle, that is where we call it as a bulge. Okay, fine. This terminology has to be very clear to us, that this is the hair bulge where this muscle is being inserted. Okay, and because of this, the hair is divided into upper segment and lower segment. This is one point. Second point is that this is the sebaceous gland, sebaceous duct. Okay, and because of this, the hair is being divided into infundibulum and isthmus. Okay, this much part should be very clear to you straight up. Now we discuss about all these things. Now one important point that we have to remember about the hair bulge. Okay, now if we know this point, then it is very easy for us to tell, okay fine, if there are any pathologies related to this area, so what is going to happen is that we can know that will we have scarring or will we not have scarring, will there be growth or will there be no growth, no regrowth. Yes, so if we just know this one point, right, about the hair bulge, we are all good to know. So what is that point? That the hair bulge has stem cell. Okay, the hair bulge has stem cell. Okay, so because of that, so if this stem cell for any reason, XYZ reason, it is damaged, so what do you think? It is going to be a cicatricial or non-cicatricial? It means like it is going to be a scarring or non-scarring alopecia. Tell me, it will be a scarring alopecia, right? Okay. Okay, so if there is going to be scarring alopecia, do you think the inflammation will be there or not there? We will come back to a very good differentiation between both these two topics, that is cicatricial and non-cicatricial alopecia, in a while. Okay, for now just the hair structure. As you can see, this is one more image I just added at the very first. Maybe it was not clear. If you want, you can go ahead with this as well, right? So this was the part where we call as the hair bulge, where the muscle is being inserted. Okay, this is the hair bulge. This is the sebaceous gland. Okay, so infundibulum and isthmus. The sebaceous gland divides into infundibulum and isthmus. Okay, and this is the hair bulb. This is where we have the stem cell. Okay, and if this point is damaged, what is going to lead to? It's going to lead to scarring alopecia. Okay, or for any given reason, if this is damaged, and if this is not damaged, okay, if I say any condition where this part is involved, just for example, like I'm just giving you example, like this part is involved and this is saved, do you think the hair will grow back or no? Yes or no? The hair will grow back. Yes. Okay, because we have the stem cell, it can regrow. Even though like we cannot know, like okay, we cannot see any hair, the hair is gone, like it is totally, we have a smooth surface, but we know the etiology very properly, we can give the patient a good confirmation that okay, fine, your hair will be back. Like if we know what is the exact reason, we will be very sure about how should we proceed with our consultations. Okay, so keeping that in mind, next topic is types of hair. Okay, types of hair. First hair, like the when the babies are born, the little angels, they are born, right? So the hair that they have, it is very different. Like I guess for sure a lot of us has hold just the newborn babies, we feel that right here we see this little angel looking at us. This is what the hair that we usually call the baby hair, right here you see the nugo which is there. Okay, and what happens is this hair is being then converted, yes, to other form of hair. Okay, we have villous hair and terminal hair. Okay, so lanugo, fine and soft hair which is androgen dependent. This is the lanugo. Okay, fine. The vellus hair which is there. Now this question is very important. If you understand this topic, you will have this question in your mind. Okay, let me just put it that way and we learn about it. So two types of hair, that is vellus hair and terminal hair. Okay, vellus hair is soft, fine, alright, and the terminal hair is thick. And one more thing, I just want you guys to take a guess about the androgen sensitivity. What do you think? They are androgen dependent or androgen independent? Think with me that these two types of hair I just described you, three types, right? So first of all was lanugo, vellus and terminal. This I'm telling you that this is dependent. What do you think about this vellus hair and terminal hair? Are they androgen dependent or independent? They are androgen independent. That is, these are androgen independent. Vellus hair, fine, no problem. Like it is just a very peach fuzz. The name, the internet name for this, the vellus hair is peach fuzz. Like the facial hair usually women have. The very very small hair, soft hair which we have. Okay, not we, the women have. Alright, fine. That is one example for that. And how about the terminal hair? They are thick, right? And they are androgen independent. So if I am telling you that the terminal hair, right, the location of terminal hair are all over the body, it is on the head as well. If I am telling that it is androgen independent, then why there is androgenic alopecia? Simple. If I am telling that okay, fine, this is androgen independent, no, we don't need androgen, like nothing, there is no relation with that, then why in androgen alopecia these hairs are lost, right? It is a very valid question. What do you think should be the answer? Will be the answer. So let me give the answer to you. The answer is that the androgen sensitivity, it is in the hair follicle, inside the hair follicle, not the type of hair. So what are we reading? We are just reading the type of hair. The follicle is going to be the same. Yes, so the receptors are in the follicle. They are really not concerned about their vellus hair or their lanugo or their terminal hair. Okay, you got the answer. If you read this, you will get it more clearly. So the answer is that androgen receptors are in the hair follicle, not the output, the type of hair. Okay, alright, so this is the hair follicle. Okay, and these could be the different types of hair. Okay, you got the point. The antibodies are made against this. In case we take one example, alright, and if there is androgenic alopecia, it is against these receptors over here, right here. Okay, this guy is also involved. All said, well and done. Let us go on to the next topic, that is the hair cycles, right? The hair stages of hair cycle. Okay, the famous mnemonic, that is ACT, okay, is coming down. Hair cycle stages which are there. So I guess everybody, we know 100% we know this, but what do we don't know are the proper, what is the mechanism, right? In anagen, what happens? Telogen phase, what happens? Okay, so we'll read about this. Fine. Okay, fine. So first one we have over here is the anagen phase. Okay, how about the second one? This is catagen. How about the third one? This is telogen. Okay, so the mnemonic remember this by is act. Okay, so maybe we forget the stages, maybe we see sometimes telogen first, sometimes we say catagen first, so always remember this once easy mnemonic, that is act, A C T. We will never miss up the order. Alright, so let us come to the anagen stage. Okay, alright, so but before that just answer me these few questions because we invested time in our diagram. We are reading about stages of hair cycle. Okay, but first tell me the parts of hair. What did we read about? We read about the electoral pylori muscle. It was inserting. What was that point? It was hair bulge. Yes, because of that, what were the two parts of hair? It was the upper segment and lower segment. Okay, alright, do we remember this much? Okay, we only need this part. Okay, if you guys know that much, it is fine. Now we can go ahead with this. So I'm just gonna give you a very good brief overview about it, and then we'll come to this. Now you see over here, that is these are the hair cycle stages. First of all, we have this one, that is in the anagen phase. Okay, so most of our hair are in the anagen phase. So the distribution is 3 year, 3 month, 3 weeks. Easy to remember. This is the range, but this is the easiest to remember. That is 3 year, 3 month, 3 weeks. That A, C, T. Questions will never go wrong. How about this? Yes, so we have this anagen, catagen, telogen, and everything starts all over again. Okay, fine. In the anagen phase, you see this is the upper segment, lower segment. Okay, so just follow this. This is the upper segment, this is the lower segment, or this is the hair bulge. At the very bottom, we have the hair bulge. Okay, now you see over here, do you see any difference? Do you see where is the lower segment? The lower segment is gone. Where is the upper segment? Do you think it is still the same? Yes, it is the same. Yes. Which stage is this? Catagen. Catagen stage. What can you say about the diagram? Tell me. In catagen stage, what do we see? The upper segment is absolutely normal. The lower segment is the one which is constricted. And do you think because of this, tell me, do you think the bulge went up? Yes or no? The bulge went up, right? Okay, fine. You got it? Where is the lower segment? Gone. Absolutely gone. Where is the upper segment? 100% there. Did anything happen to the upper segment? No. At the very end, what happened? The upper segment is also 𝗖𝗵, like bye bye. Yes, it's okay. So even the upper segment is gone. Yes. So what's gonna happen? You see here, new hair formation. Okay. So anagen, catagen, telogen. After the full cycle, what happens is the hair is being broken. Yes, okay, fine. One more question. I hope this you guys understood this. So we will be reading exactly the same thing once again in the tabular form. So let us begin. So we have the anagen phase. In anagen, it is also called as a growth phase. Okay, 3 year it will be just here in the growth phase. Okay, it is the anabolic phase. Anabolic phase means the growth phase. Yes. What about the catabolic? Catabolic means destructive phase, right? Catabolic means destructive phase. Okay, anabolic means synthesis. Okay, anabolic means synthesis. Yes, and the catabolic means destruction. Okay, alright, fine. Okay, so a majority of hair are in the anagen stage. Okay, that is the almost 86%. These numbers we have to know. 86% of the hair are in the anagen phase. What actually happens is the upper segment and lower segment of hair are formed in this. Okay, so our good old diagram, the upper segment and lower segment are formed in this. Okay. Alright, one point is clear, that is we are done with the anagen part. Let's go on to the next part, that is the catagen. In catagen, this is 3 months, right? It's only for, it stays for 3 months. Yes, it is the involution phase. Involution phase, what does this word mean, involution? It's not, it just means like it is shrinking, regressing. This is what involution means. Okay, so like if we just know the meaning of the word, like just simple English, 100% we are good with it. Okay, because maybe this and this is easy. This meaning maybe somebody knows, somebody don't know. So involution means regression. Okay, this is a regression phase. Do you remember what I told about the lower segment? Do you remember what happened to the lower segment? Okay, you see here. Okay, connected, well connected. Lower segment shortening, upper segment something happening? No, upper segment is normal. So I have not even written here. Upper segment is normal. Okay, so if you know the story, we will revise this once again. If you know the story, it is so simple. The concepts get so simple, you know, like, okay, I know it. I absolutely know the hair cycle. It's not just like anagen, catagen, telogen, 3 months, 3 years, 3 weeks and then I'm good with it. No, you should exactly know what is happening in the hair. Okay, alright, so I hope so far we are good. That is the LS, lower segment shortening. So what is happening is because of the lower segment shortening, that is involution, right? So what is happening is the hair bulb is coming up. Okay, the hair bulb is coming up, as we can see here. The hair bulb was here, the hair bulge here, now it is here. Okay, fine. One point is cleared very clearly. Now we have the telogen. Okay, after telogen, what's going to happen? Bye bye. The hair is going to get uprooted. We'll get a new hair. How many hairs are normal? Like daily we have hair fall. Like what is the normal range of daily hair fall? It is 100 to 150 hairs are normal. Okay, they will shed daily. Okay, fine. So what is happening in telogen phases? In telogen phases, the lower segment is lost and upper segment remains. Okay, and after this stage, even the upper segment is gone. We have a new hair formation. Okay, so I hope this is the point of 100 to 150 hairs are fall per day, and they re-enter into the anagen phase. Like right here, they would get back. Okay, so I hope this one topic is very clear to you. Yes, it should be very clear. Yes, because the coming chapters, we will read about alopecia areata and all these things. So if you know these things correct, and telogen effluvium, anagen effluvium, if you know this one concept correct, so I can build things very easily on just these two things, this one hair cycle and the previous diagram. Okay, these two things we know, we're good for this chapter, the disorder of appendages. Okay, fine. So we go on to the next one. Alright, we will start with alopecia. Okay, with different types of alopecia we'll learn, but first we have to do with the classification. Alright, so let us start with the alopecia chapter. Alopecia, what does it mean is loss of hair. Very simple, loss of hair. Okay, but okay, fine, even if the hair loss is happening, there could be different features about it, right? Let us just put it this way. There could be different features. Okay, so it could be scarring or non-scarring. Scarring or non-scarring. Okay, alright. So if it is scarring, what do you think? Yes, what do you think? Will there be inflammation or not? This is the question I ask. Non-scarring, no inflammation. Simple. Non-scarring, no inflammation. And what do you think about the cicatricial option? That is, if there is scarring, there will be inflammation. Okay, as simple as that. There will be inflammation. Okay, so I hope these two things are very clear to you. So we will be reading about extensively about this chapter, and so many different types of example we will be covering as well, one by one. But first you should know like which example comes under which heading. Okay, that is one thing. Now we go on to the next one, right? So now we go on to the next one. Alright, so if there is alopecia, fine. Okay, so what type of alopecia could be there? One thing, what type of alopecia could be there? I can either just do it on the base of the body, the way how the body reacts. Yes, it could be either autoimmune, or it could be either some because of some abuse, right? Or either I could do it because on the basis of classification about the pattern, right? The pattern I can see. Maybe the pattern is diffuse, yes, maybe it is some partial, maybe it is patchy. We have three different types of classification, and each has example. Everything is important here. Some could have autoimmune related issues, some could be because of some stress. Yes, usually one we will see about one of the condition, right? In the effluvium, we will see because of the stress. Just because of the stress, what is happening is the hair, right? A lot of hair, they enter the telogen phase. If a lot of hair enter into, what I told about telogen phase was that only 100 to 150 hair we lose every day, right? But just imagine if a lot of hair are entering into the telogen phase, so the next step is bye bye. It will just get uprooted and we'll definitely have new hair, but a lot of hair loss, right? So I'm just giving an example that if there are a lot of hair just being moved into the next stage very suddenly, so what is going to happen is like the hair, there would be so severe hair loss that 1,500 hair could be lost in a day, because the main reason for this is increase in corticosteroids during the stress period. It could be because of pregnancy, it could be because of exam stress, personal issues. We see like somebody who is constantly like he's just bothered about something, we feel it in our friends, in our families. Somebody could be just stressed for like something, because like usually people have different personalities. Some people would be like, okay fine, they are very chill people, they don't get worried, they are like fine, they have a good hairline. But some people who are very stressed all the time, right? You see they don't have much hair because of this reason. Our counseling should be very important to the patient. Okay, Alright, and also the way we live our life, the way we think, the way we proceed with everything, it should be very important that we should take good care of ourselves, even though the profession doesn't allow it, because it is a very hectic thing, right, in our profession, to maintain the personal life, the professional life, and everything along with it. Alright, so it is very important to take care of ourselves as well, right? Okay, so let us just continue with this. That is different types of alopecia we were talking about. So first we have the patterned alopecia, right? Some particular pattern would be followed over here. Definitely we have the androgenic alopecia, right? So androgenic, so because of the increase in the what, right? Tell me. Because of increase in the testosterone, right? So do you think because of testosterone it is we having hair fall? So testosterone is not that potent. Yes, if we just say so, if the testosterone is converted into DHT, that is a dihydrotestosterone. That is what it's potent, right? That is what goes and it just stimulates the androgenic receptors, and then we have thinning. First will be thinning. Don't tell there will be hair fall. No, these are not antibodies. Okay, these are not antibodies. Right? The DHT is not antibodies against the androgenic receptor. Okay, what is going to happen? There will be thinning of hair. The hair will be filamentous, right? Very thinning of hair, right? Vellus hair formation, thin hair, soft hair, and then they go. Okay, fine. The next one could be a patch. Fine, there could be a patch. Yes, so patch alopecia areata, I think no need to teach. We know it. We know very well, right? We know very well. Another type of alopecia I taught in the chapter of which one? In the STDs. We just got done with STDs, You should remember the secondary syphilis. Tell me, what is the pattern? What is the pattern? Tell me. If you are able to even imagine that picture, if you are able to tell, if you are able to write well and good, you are listening properly. You have your concentration right. You are not checking your Instagram or some replying some DMs. You are properly focusing on the video. Okay, fine, good job. The answer is moth-eaten appearance. Secondary syphilis has moth-eaten appearance. So it is very important. We should know syphilis. Everything we should know syphilis. We discuss so much about syphilis, extensively, primary, secondary. We have congenital, we have this neurosyphilis. Yes, so we did so much about the whole topic. So we should know about this. Okay. So other examples are trichotillomania. What is happening here? We will discuss each and every we will discuss in detail, but I just want to give you a very quick overview. Okay, so when we start a topic, it is very easy for us. Okay, so we have the trichotillomania. In trichotillomania, what is happening? Is this a psychiatric condition? Is this Dr. Nadeem sir's topic? Yes, this is right. This is a Dr. Nadeem sir topic. This is trichotillomania, pulling of hair. Right, so like somebody is, they have this sudden urge. This is an OCD, right? This is an obsessive compulsive disorder, right? Like sudden urge to do something, continuous urge. Like if you don't do that, like the person is very uncomfortable. So what are the examples? Repeated washing of hands. Does the patient has insight? Yes or no? Tell me. Insight is present or absent? Yes. If I don't answer this correct, Nadeem sir will tell me. The answer is insight is present. Yes, in OCD the insight is present. So the person knows that because of his habit, he is not able to do something. Okay, alright, fine. That is one thing. So that is about trichotillomania. Okay, we'll be reading more about this. 𝗔𝗵 capitis is also there. We read tinea flavum, tinea. We read about 𝗔𝗵 capitis, right? I hope you remember the image properly. We read extensively in the bacterial skin infection chapter. Okay, fine. How about the next one? This is the diffuse pattern. This is the diffuse pattern. This is where the exam stress comes in. This is the diffuse pattern. Okay, so this has two types, that is the anagen effluvium and telogen effluvium. Okay, alright. Effluvium, right? Effluvium means fall. Okay, effluvium means fall. Alright, so fall of hairs in the anagen phase, fall of hairs in the telogen phase. Okay. Okay, so let us just start with our discussion. Okay, so over here we just got completed with the classification. Okay, like a very rough classification. Okay, we had the cicatrial, non-cicatrial one, scarring, non-scarring one. Okay, so we'll be first talking about the non-scarring one. Okay, so all these are non-scarring. Okay, so nothing much to worry about. Yes, we have to worry about, but not the scars. So first we'll be taking the patch section. Okay, alopecia areata, trichotillomania, secondary syphilis, and 𝗔𝗵 capitis. Okay, so we'll be doing these first. Okay, fine. So here we go. non-cicatricial, non-scarring. Okay, we are going to start with alopecia areata. Okay, this is the patchy hair loss. So, but what do you think is the reason for it? Okay, we just start with this one. So, what do you think is the reason for having the alopecia areata? Right, this is the autoimmunity, right? Because it is an autoimmune condition. Okay, so we have antibodies made against what? That's the question. Let me write the notes for a while. Autoimmune condition. Okay, so antibodies are against what? The sebaceous gland, the hair bulb, or what? Yes, who is the antigen? Just tell me, who is the antigen here? If you understand this one point, all good. Yes, so the antigen, is the melanin pigment. Okay, so I guess a lot of students, we miss out over here actually. We know alopecia areata, we can even solve the questions, but we don't know actually what it is. What is the antibody and who is the antigen? Yeah, that is the melanin. Okay, that is the one. If you know, okay, that we just discussed about when we were drawing our diagram, when we were labeling our diagram, right? So we read about the stem cell. Where was the stem cell? In the sebaceous gland? No. Where the 𝗲𝗵𝗵𝗺 muscle was getting attached, right? Over there. Okay, we had the hair bulb. Yes, hair bulb had stem cell. If this is damaged, do you think it's going to be scarring, non-scarring? It will be scarring. But is this condition scarring? No. It is reversible and it is non-scarring. Okay, did you get the point? Now, did you connect the two things? I'll repeat once again. When we read it before, when we were labeling our diagram, right? So I told you that where there is we have the 𝗲𝗵𝗵𝗺 muscle, it is getting inserted right into the hair follicles. That part is known as a hair, what is called as hair bulge. Okay, that part has stem cell. If that stem cell is damaged for any reason, okay, so we will have scarring alopecia. But in this, what is the antigen? Tell me, who is the antigen here? Is the stem cell the antigen? No, the antigen is the melanin, right? You see right here, the melanin pigment is the antigen. So what is going to happen is, because of that, yes, because of that, what's going to happen is there will be no scar. That is the reason we are reading this topic under non-scarring alopecia, non-cicatricial alopecia. We are reading it under. Okay, all right. So and it is reversible. Okay, it is a reversible condition. Okay, fine. Yes, it is reversible, but there are certain poor prognostic factors as well. So we have to know that. Okay, we have to know that. Okay, so that is very important. All right. Why? Because if we see like those points in a patient, right? So we can tell them, okay, like definitely we'll try our best, but so and so is the condition. But if you know that, if you know there's this point that, okay, fine, alopecia areata has a very good prognosis, then you will be like, oh, good. But you don't know that one point I have included in the very last line of this chapter is that. Okay, so we'll be reading about that as well. Presentation, tell me, how is the presentation? Is it like good? How is it? So this is the image, right, of this. So you can tell that it is a very well demarcated circular region. This is a female patient. Probably it is a female patient. Yes, so that is why we have like this. If it was a male patient, then because in case he or she would have short hair, so we could see the lesion very clearly, right? So it is circular, well demarcated lesion. Okay, all right. So well demarcated circular patch. Okay, where it can happen, yes, it will be smooth. The area where it happens, right, the patches are smooth. Okay, all right. Why smooth? We should know, because in the next one we will read, right, we will be learning about hair breakage. Yes, so in that condition it is not smooth. We have some different findings over there. So this point is important here. Okay, so please mind it. So scalp, beard and eyebrow, it can happen anywhere. Okay, over here we have one condition, right? Because of this we have this. It is a very classical feature over here. Okay, so this is known as exclamation hair, right? Exclamation mark. Okay, that is one thing. So first we just have a normal hair, right? This is the normal hair. I hope you can really appreciate my drawing skills. Okay, all right. So normal hair, this is it. Why I'm telling you this is because you see the at the very top, you know, it is not, we don't have a base at the top. At the top it narrows, right? So it has sort of like a triangular pointing structure, right? But over here you see it is inverted. Okay, so this is the hair bulb. Yes, this is the hair bulb, and right here if you see, the structure is just like this. Okay, we have an exclamation mark. Okay, all right, and because of this we find this. Okay, in the periphery we would find the hair, right? The exclamation mark sign would be seen in the patient. Okay, all right, so coming to the next point, that is this. These are the patients. Okay, yes, in this patient we can definitely see that this is alopecia areata. Okay, all right, so question to you, if you have been listening it correctly, you listening it proper concentration, you will know. Can you define this image? Waiting for you guys to properly observe it. Yes, tell me. Good clinicians, we have good observing skills. Okay, this one as well. Anything? Okay, so I hope you guys have thought about it. Yes, let me describe this. Well demarcated. Yes, circular patch is also there. In this one is quite a huge patch. Okay, but now just connect the concepts beautifully. Beautiful concept connection. I told you that the antigen is against the melanin pigment. You got it? Antigen is against the melanin pigment. Now over here, can you see the white hairs are being spared? The white and gray hairs are being spared. Okay, now you get the concept. Okay, so if you, even in this one, you see the white hairs, the gray hairs are being spared because the antibody, the antigen is not made. Antigen is the melanin pigment. Okay, not the hair follicle. They are against the melanin pigment. Okay, you got it. So we should know whenever we study something, right? We should know it in depth, in detail, like everything we should know about it. So then we get the confidence. Like, yeah, we know it. You know, it is not just about the exams, and you know we limit our knowledge to the PYQ part, right? This is a detailed series we are reading, so we have the luxury of time now. We can go in extensive detail and we can read everything properly. Okay, fine. Let us come back. So this is melanin pigment thing I focused a lot upon, right? And these are the two images. Okay, all right, so now we will go to the nail finding in alopecia areata. Okay, what are we going to see is there will be regular pits. Yes, we'll find regular pits will be there. Okay, all right, pits were seen in what? In psoriasis also we saw some pits, right? Very peculiar nail findings. Okay, yes, hyperproliferation, hyperkeratinization. Okay, all these things we read so much in psoriasis topic. Okay, regular pits is the answer here. So nail findings, yes, we'll see the images, but first we'll write this regular pits. Okay, they are transverse and they are longitudinal, right? They are transverse, they are longitudinal pits, we can say right here. So we should be knowing them very properly, right? Okay, the nail findings are very peculiar. So even in the image based discussion, I will include all the images about hair, nail, like everything will be there, and it will be quite a good discussion. Okay, all right. Trichomoniasia 20 nail dystrophy. We read about this before as well. All the nails are involved. Okay, fine. So we're done with the nail finding over here. Now let us go on to the histopathology. What is actually happening? Okay, what is actually happening? We'll see about that. Okay, fine. So what is the one thing that I want you to remember, right? Is shown in this diagram. Yes, we'll write the notes as well, but first we see this is the hair. Yes, this is the hair follicle which is there, and you can see, you can really appreciate this part, right? That it is not a very free filamentous sort of thing, right? It is being broken up. Yes, okay. Now what is happening is this is we see the hair bulb part. Yes, this is where the melanin pigment is. Okay, this is what the antigen is. You got it? Did you get the concept right? This is where the antigen is. Okay, so this is where we have to attack. The body thinks this is where we have to attack. So what is the body going to do? Body is going to sell all the lymphocytes. Okay, so against the hair, right? Body is going to sell all the lymphocytes. Okay, fine. Once it is there, right? So how is this appearance? We will see. This is the peritubular lymphocytic infiltrate, right? We'll see. Okay, so on a histopathology, this sentence is very important. What is the sentence? What is this? Peritubular lymphocytic infiltration. We'll see. Okay, very standard thing we should know. We have to remember this. Okay, and what is this appearance called as? Now this becomes more important because this has a specific name to it. Okay, so this is swarm of bee appearance. Okay, all right. So two sentences, two histopathological finding is a must for us to remember. Okay, so we have peritubular lymphocytic infiltrate. Okay, and the next one was swarm of bee appearance. Okay, swarm of bees, like these ones. Okay, so like these are swarm of bees attacking to the hair follicle. Okay, some of bees maybe going to the beehive. Okay, swarm of bees. Okay, all right, swarm of bees. Okay, so this condition has some associations with it. Yes, so what is it associated with? Okay, first of all, we have Down syndrome. It is associated with Down syndrome. Okay, fine. Trisomy 21. Okay, atopy. This is very important. We have to remember this one. Atopy and lichen planus. These 2 points I want you to read. Okay, fine. So these two things are there. This is atopy. This is type 1 hypersensitivity reaction, that is localized one. Okay, ACID, allergic. Yes, this is the type 1 hypersensitivity reaction. Okay, we see the in atopy. We see this. It is also seen in autoimmune condition like lichen planus. Okay, we read so much about lichen planus, right? Purple, flat top, violaceous lesions are lichen planus. We read about the Neil findings. You guys remember pterygium, lichen planus. Okay, fine. Atopic dermatitis as well. Okay, alright. This is atopic dermatitis. Is what? This is eczema, right? So everything we have done. Okay, we just have to read the whole thing, and we are good. Fine. So we are just done with the associations, right? Associations as of the alopecia areata. Okay. So now we'll go on to the different types of alopecia areata. Okay. So there are 2 types. That is alopecia totalis, also known as alopecia universalis. Alright. So and the second one is alopecia ophasis. Okay. So what happens in this condition is there is specific loss of hair just in the occiput area, like occiput area, temporal area. Mainly occiput area, we have this hair loss in the back side. Okay, so why should we know? Like we should be able to differentiate. Okay, if I ask you a question, is this trichotillomania? Tell me yes or no. Like if you know this one point about trichotillomania, you will just vomit the answer right away. Okay, I will not tell you the answer now. I will tell you when I do the topic. Until then, alopecia universalis. Do you see, like this person is also showing his previous image, like he had a good afro, right? You see, but now he doesn't have any hair per se. On the eyebrow hairs are also gone, the eyelashes are also under attack. All right, so there's no hair to be found, right, on the face and above. Okay, so this is alopecia universalis, alopecia totalis. Okay, right here you see. Okay, all right, so we have these 2 patterns are done. What can we do about this? Yes, and what can we do about this? Yes, so we definitely have a good treatment. Yes, very good response, very good response to that. Okay, but we have to know the poor prognosis factor. Fine. Okay, just don't remember that one line. We need to remember everything together. Okay, what is the treatment? Yes, I know you have only one word in your mind, that is corticosteroids, and yes, that is the answer. But other than that, there is a very interesting therapy that we give to the patient. We will be discussing. It is just the next one. So intralesional injection of corticosteroids. Yes, so we just we'll prepare an ampule. Yes, the 1 ml ampule, we'll load it up, and definitely we'll just insert in all these areas, and a very good result. Okay, all right. So the treatment option, right, that I was just talking just a minute ago, that was contact sensitization. So what firepower do we have, right? So this is one of it. Okay, so contact sensitization, what happens is we use these drugs like DPC and DNBC, that is diphencyclopone and dinitrochlorobenzene. So these 2 agents which are there. Okay, so what do they do is, yes, we ask the patient to apply it on the lesion. Okay, so what they do is, like, these chemicals, right? Okay, fine, this is the hair follicle, this is the part. Okay, this is the part where the antibody is against, that is a melanin pigment. Okay, right here. Okay, fine. So we ask the patient to apply them. This product, right, this drug, it gets absorbed in the skin, and what happens is, when it reaches here, so these are a very strong allergens. They are very lucrative, right? So what the body going to do is, the body will have something known as antigenic competition, right? The body going to have something called as antigenic competition. So what's going to happen is, the body will choose to attack them, not the hair follicle. Now this is safe, this is gone, the body will attack this. Okay, alright, did you get it? This is known as antigenic competition. Okay, it's very important, we should know, we should remember, it's very interesting, right? So these two drugs and this point we should know, very important to know. Okay, so what I just explained this point, that is in antigenic competition what is happening is the autoimmunity, our body immunity, it ignores the hair bulb and attacks the stronger allergens, that are these. Okay, did you get it? Now we have the concept, now we can write our notes. Okay, fine. What should I write here? These are stronger allergens. Okay, alright, and also we can definitely give systemic steroids, yes, and 𝗲𝗲𝗹𝗵𝗺, and topical minoxidil has a very good response to it as well. Everywhere hair follicle is a hair fall, we will use minoxidil, right? Topical minoxidil, and phototherapy is also been proven to useful to this patient. Okay, now coming on to the point that I was talking about earlier, the poor prognostic factor. Okay, so if any patient comes to you who is very young, probably a child, you have a pediatric patient, yes, and we see in this patient, like, yes, there is very aggressive alopecia areata, very aggressive, so it has a very poor prognosis. Okay, so I have seen one patient, yes, for alopecia areata, which fits under this condition, yes. Otherwise, if adult would have it, right? So one of my friend in the university, right, so he was having this, he had a patch right here. Okay, so yes, we were able to diagnose him, and we just gave appropriate treatment, and yes, he had a very good results about it as well. But in that child I saw, he was taking the medication, the treatment was going on for almost 2.5 3 years, and still the lesions were so huge, like we could at least count like 6 lesions we could see. Okay, so if there is early onset in any patient about this disease, so it has a bad prognosis, so we should remember this point. Okay, so atopic dermatitis, yes, that is one thing. Eczema, and in early onset, that is in the childhood. Okay, and ophasis, that is we just read about this. What was it? These are a particular type of alopecia areata, right? One we read was alopecia universalis and alopecia ophasis. In this, the hair near the occiput, right? These are mainly attacked. Okay, alright, so we have these two conditions. So next up we have the trichotillomania. Okay, we just read about this, right? So trichotillomania is what? It is an OCD, obsessive compulsive disorder, right? Obsessive compulsive disorder. So what is it? It is the irresistible urge to pull one's own hair cells. So it is an irresistible urge to pull one's own hair. Okay, so it is just like it is an OCD, so the patient will be doing again and again and again, and yes, the insight will be there. Okay, but one question to you is that the length is irregular. Why? Very interesting question. Yes, so why there is irregular length? What is the reason we have irregular length? As you can see the patient as well. The answer is that whenever the patient was trying to pull the hair, right? So what happened, like when the patient is pulling the hair, sometimes they might use a lot of force, sometimes they might use a very less force. Okay, alright, did you get the point? Because there is difference in the pressure we apply on the skin to pull the hair. Okay, that is the reason. Okay, there is imbalance. That is one point we should remember. Let us write that down. So irregular length we see in because of there is difference in pulling force. And incomplete hair loss, unlike what? Yes, it is an incomplete hair loss, unlike we just did that point, we just did that subtopic, that is alopecia areata, right? Unlike alopecia areata, I am talking incomplete, I am not talking complete. Okay, so it means that alopecia areata has complete hair loss in that patch. Okay, unlike alopecia areata. I should have a different color, but okay, fine, no worries. So one more question in histopathology. Okay, fine. So what is going to happen, like in this patient? Okay, if the hair was very long, like if the patient is trying to pull the hair, so do you think there can be some extravasation of blood? Could be, right? Could be, So do you think there can be small microhemorrhages? Okay, so I'll just show you the image first. All right, Did you guys get it? Because of the pulling, right, there is perifollicular microhemorrhages. That is what we can see. In this patient is quite too much, but yes, you see these microhemorrhages you see. Okay. Alright, so now if you remember that question that I asked you, that how would you differentiate between the ossiferous alopecia areata, yes, and the trichotillomania. So this was the answer. What is the answer? That you see there is no microhemorrhages. Do you see microhemorrhages? No. Okay, did you get it? Clear? Very clear? Yes, so we should know about this one, like if you see microhemorrhages, it goes in trichotillomania. No microhemorrhages at the occiput, it is alopecia areata, the ossiferous type. Okay, and this is the universalis type. Okay, alright. So I just mentioned you about this one, that is peritubular inflammation would be there. Okay, and we'll see perifollicular hemorrhage, yes, due to the pulling of hair. Okay, fine, that is due to the pulling of hair. Okay, how about the complication? What can happen is, like, some patient can pull the hair and they can eat it. They will pull the hair and they will eat it. What is going to cause? It's going to cause obstruction, right? It's a very famous this is the stomach 𝗲𝗵𝗵𝗺. In surgery we read about this. Yes, we read so much about this. Yes, 𝗲𝗵𝗵𝗺, you see, in 3 types of 𝗲𝗵𝗵𝗺 are there. There is stomach 𝗲𝗵𝗵𝗺, duodenal 𝗲𝗵𝗵𝗺. Yes, this is the small intestinal 𝗲𝗵𝗵𝗺. Okay, the demarcation is also so clear. Okay, alright, so we also see this one snapped string. Okay, alright, so that is one thing that we need to remember, that is these are the complication of what trichophagia lead to 𝗲𝗵𝗵𝗺. Trichophagia. Okay, what would be the treatment? It is psychiatric condition, right? Okay, so first of all we have to refer. Okay, we have to give proper counseling. Okay, so SSRI we would be using, okay, in it. Alright, and we will give behavioral therapy. Yes, that is very important. Okay, CBT or behavioral therapy we will be giving to this patient. Yes, and good response is there. Devices, what device? So this device is this is the new point I added over here. So what does this device do is, like we know, like the patient is just going to pull the hair whenever the patient has an urge. So what does this device do is, like, for example, whenever the hand goes up, yes, so the device can detect this movement, this particular movement. Okay, like sudden movement the device will detect. So what is going to happen? There will be vibration in the device. Okay, so this will lead to a negative feedback. Okay, like I don't have to do it. I don't have to do it. Even when the patient has urge, like the device will vibrate and there will be a response to it. Yeah, so we can use the CBT, we can use the device, these handheld devices which are there, right? And when we can use SSRIs. So a combination of this has a very good result. Okay, alright, so now we have done with 2 topics over here. We are done with alopecia areata, we are done with the trichotillomania. Okay, now we'll go on to the secondary syphilis part. Secondary syphilis. Okay, so what is the finding in secondary syphilis? We read about. Yes, so this is what I have mentioned over here as well. So if you go to our notes, yes, to page number 162, we discuss about this, right? Okay, what was that? Over here we have something called as moth-eaten appearance. Okay, we have moth-eaten appearance. So this is the straightforward, this is a screenshot from my notes. Okay, alright, page number 162 we have it. Hair loss, we have moth-eaten alopecia. Right here you can see. Alright, fine. Okay, how about the next one? Okay, so we are done with that whole thing. Now we are going towards the patterned alopecia. Okay, patterned alopecia, we'll see about androgenic alopecia. Okay, androgenic, because of the androgens. What types of alopecia could be elicited, we'll be reading about that. But first we should know about the receptors. If we know about the receptors, easy to understand. Where are these receptors? Why in males, right? Because we usually have the hair loss from the vertex, right? Yes, on the frontal and the vertex area, the hair loss is seen. So why do we only have hair? But like, and you see over here, like, in the temporal area, the occiput area, like these hair will never go. Whatever you do, even if you do, like, daily trauma daily, so this hair will be there all the time. Why? Today we will answer that question. not just like because they had to go they went. This is not the answer. The answer is in the receptors. We'll come to that. Let us just discuss these couple of points first. That is the androgens. The androgens are the one who are mainly responsible to it. Yes, that is the whole point about. And yes, this has, because it's androgenic, so the genic part means that it has a genetic predisposition to it. Okay, alright. So if grandfather, father doesn't have a very good density of hair, definitely the upcoming lineages don't have a good probability of having a good hair density at that age, or they might lose their hair pretty early. Okay, it just a predisposition to that. Alright, nothing much. Androgenic receptors. So where are these androgenic receptors? They are in the frontal and the vertex area. They are present. Okay, and these androgenic receptors are absent in the temporal and the occiput area. They are absent. Okay, so you can just see right here, and I hope I did spend a bit of time drawing this diagram, so I hope you can appreciate that. Okay, fine. So this guy has guys, right? All guys. Okay, fine. We have androgenic receptors on the top area, right, and on the frontal area. Fine. That is the reason we have that there is specifically balding starts from here, right? The W pattern which is there. You see, yes, this is the reason it starts here. Okay. All right. So now you understand the reason. Yes, why is it actually happening? Okay. So because of the presence of these androgenic receptors, okay, we have alopecia, which starts from the vertex and the frontal area, and the temporal, occipital, and the temporal and the occiput area, right? So they don't have these receptors. The hair follicle, they don't have these receptors. Okay, that is the reason there is no hair fall. Okay, I hope I answered that question, right? That why do we have hair fall over here only, right? Like the start of hair fall happens here. Definitely it's because of traction and this and that, all are there. Genetic predisposition is there, but yes, this is one point we have to know. Okay, alright, and this is the reason the whole mayhem is happening is because of the testosterone, right? So testosterone has been converted to DHT by what? 5-alpha reductase. 5-alpha okay, alright, so that is one thing we know. And I guess, and right now this is the point like of abuse. Yes, almost abuse, in the whole internet, in the pharmaceutical sector, and in the nutraceutical sector especially. So what is happening is people just read about a few things online, that yes, they see that okay, fine, hair loss is happening, take this drug, apply that serum, do this, do that, and people would do it. Yes, so if 100 people are doing some sort of quack knowledge they are using, so what's going to happen is at least somebody will have good results, and these are the ones who make the most noise. Okay, now the person who was not involved is involved. Okay, now they want to use that as well. They just take up these inhibitors, like finasteride. There are very specific conditions, right? We use it. We don't use it in normal people. So what's going to happen is like if the person is about to make his family, right? They just got married, they're planning a family, and he has some hair loss. They started the drug, right? Because of he saw somewhere on the internet, they saw something. What happened is like they cannot have a successful fertilization, right? They cannot have a pregnancy because the DHT levels are less. Yes, we are blocking it because we are blocking it, right? Because of the drug. All right. So what is happening is because of like the person is taking finasteride or any sort of this 5-alpha reductase blocker, so the DHT levels are low. Okay, so this inhibits the whole reproductive system, right? Fine. So we should be very careful about all these things, not just straight up take drugs just because someone is selling. Go to a person who has spent his life in these things, get a proper prescription, yes, and then move forward with that. And definitely consultation is the part is very important, and definitely we should tell our family physicians, the doctors, like what are we up to, right? They won't know, unless until we tell, right? So they won't know things. So that is one thing about it. Okay, fine. So let us go on. I want to make you explain what happens in this process. The hair doesn't go in one day, like the hair fall doesn't happen in one day. Okay, in this, so what is happening is there is, because of this androgens, right, these receptors are getting triggered, and because of that, what is happening? Is it hair fall which is happening, or what is happening? That is my question. The answer to this question is that is miniaturization of hair follicle. Okay, right. So that is one word we have to remember. Miniaturization means thinning of hair follicle. Then there will be shortening of hair follicle. Then will be bye. Okay, permanent 𝗖𝗵𝗵𝗺, permanent gone. Okay, all right, fine. But there are a lot of things that we can do about it, and especially now we have so much we can do about it. Yes. Okay, so let us start with it. Okay, so what we can do in males, what we can do in females, right? So we'll start with that. Okay, over here we have balding. It starts from the vertex. Vertex is this part. Okay, this part is vertex. Okay, all right. Frontotemporal recession will be there. Frontotemporal recession we have, and then we have this W pattern, right? The W pattern will be there. Okay, slowly there will be W pattern and there will be hair loss. Okay, what classification do we use is Hamilton classification. The Norwood Hamilton classification we use, and in this we have total of 1 to 7 stages. Okay, so we have to remember this part. What classification we use? Alright, so Norwood classification is very important. Norwood and Hamilton. Okay, in the males, classification is very important. Okay, alright, we just know the name is okay, no problem. Where does the hair fall start? It start from the vertex. Okay, fine. How about the female? So in the female population, right? So we have two different types of hair loss pattern we can see. Okay, so what are these? First of all, we have the Ludwig's and we have Olsen. We have Ludwig's and we have Olsen pattern. So what is what in which one there is which characteristic property we can see. So in Ludwig, right? So Ludwig, what's going to happen is the hair fall will just be from the vertex area. Alright, the hair fall is just from the vertex area, and the hairline, like the frontal hairline, is paired. One point you remember about this. Okay, so you will never make the question wrong. Okay, so in Ludwig's what happening is that is the vertex is affected and the frontal hairline is maintained, like in this one. Frontal hairline is this, then it is this, then it is this. Is it the same? Yes. Okay, yes, but the whole hair fall is happening at the vertex area. Okay, fine. Did you get that one point clear? Okay, how about the Olsen pattern? Olsen pattern, we have this Christmas tree hair loss is there. Okay, right here you see we have this. Okay, because it's and usually I think, like, because of the partition, because if somebody is making the partition, right, for like probably 10 years, 15 years, same partition. Okay, so what is going to happen? Because of this, there is something called as traction alopecia, right? Traction alopecia, because of the this traction alopecia, it always happens in a set pattern. Alright, so if any particular lady, if particular girl is just trying to make a pony, okay, in the pony, a very tight pony is usually like very desirable, but we should not do that. We should not recommend doing that. So what's going to happen is, like, because like you want that fresh look, like less, no hair is just flying here and there. Every hair is like on the in that rubber band, okay, and we have a good ponytail. What happens is, like, again and again, and if the hair pulling is there, so we will have something called as traction alopecia. So what can we do about this patient? We should just counsel them, okay, that you should go for some another hairstyle. Yes, and your hair will regrow. Okay, that is one topic. Coming to the hair loss pattern. Okay, so in the female we were discussing about the Olsen pattern, that is the Christmas tree pattern. We should remember this. Okay, the Ludwig, okay, and Olsen. Yes, so in how I remember is, I know it is very just not so good way to remember, but I always remember with this, and it definitely works for me and my friends. Okay, in Christmas, like we have this Santa Claus, right? Santa Claus, and what whenever there is Santa Claus, there is one music, like ho 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 ho, like something like this is always there. So like ho 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 ho, like this thing, this O can just should have some resemblance with the Christmas, and this will lead to like this. Okay, alright, so if that analogy makes sense, it's fine. If you have your own thing, you can use your own thing. Okay, fine, but please make sure you remember one of it, either Ludwig or either Olsen. Okay, fine. So what are we going to do about the treatment option? Okay, so now this is about the male part, this is the female treatment. Okay, treatment plan, we will be discussing about them. Okay, so yes, let us discuss about the male counterpart, and then we'll go about the female part. Okay, so over here, yes, we can use minoxidil serum, topical minoxidil. We have very good droppers are available, right? We can use oral finasteride, but with a proper counseling we will use this. Okay, what does it do? It 5-alpha reductase type 2 inhibitor. Okay, alright, and we have dutasteride, which is both type 1 and type 2 both inhibitor. Okay, so we have finasteride and we have dutasteride. Okay, these two things we have to remember properly, finasteride and dutasteride. Okay, these two things are there. What more can we offer to the patient is, we can do platelet rich plasma. What all options can we give to the patient? Okay, fine, we gave the topical serum. Okay, we gave the finasteride, dutasteride is done, but what more can we offer to the patient is platelet rich plasma, PRP. very famous, very good results. Yes, we also do it in our dispensary. What do? We have the whole machine, right? So we draw blood, we put it in the centrifuge machine, okay, then the contents of the blood, they settle down, and then we have the plasma, right, and then we load it up in the ampules. Yes, the 1 ml ampules, we load it up in the syringe, and then we will just apply it in the hair, right? We'll inject it in the hair. Very good results, okay, but it has to be done very properly, very, in a very hygienic environment, because these things, like, people just see in the internet and they just start doing it, okay, but it has to be done in a very good, clean, hygienic settings, okay. All right, fine. So that is about finasteride and dutasteride and PRP, okay, PRP. All right, so very famous, and a person can get 3-4 sessions, and the results are very good results. And the end is hair transplantation. Yes, and hair transplantation, okay, so we can just take out our hair from the good density areas and just put it in, and it works fine, okay. All right, so that is about the male counterpart, these treatment options, right. So we go to the female one. Females, yes, we would use topical minoxidil. Good response, very good response as compared to male. You see, when the females, they use minoxidil 5%, they have very good response, okay, about minoxidil. And we have the other therapy, which we have oral anti-androgen therapy. So in the females, what's happening is, if they have a lot of androgens, right, so there are conditions which have a lot of androgens, right, so like PCOS is one of the conditions, right, there are more androgens. So because of that, what happens is, there is something called as hirsutism, okay. All right, you got it. And to inhibit that, yes, we want to have conditions, like, we want to elicit low androgen condition, we want it, so we'll just inhibit it. Yes, so anti-androgen therapy, what are these? Androgen receptor blockers, okay. All right, so this is cyproterone acetate, spironolactone, flutamide, okay. All right, so we have these three things: cyproterone acetate, spironolactone, flutamide, okay. We have these three things. So yes, diuretic, yes, and flutamide, and these things are androgen receptor blocker, okay. So this is very important. And they when to use when. So this is a good question too, that it works better, they work better with conditions with hyperandrogenism, okay. When there is hyperandrogen, in these conditions, the androgen receptor blocker, they will work well, okay, then minoxidil. But if these conditions are not there, like hyperandrogen conditions are not there in the patient, you can see the patient is normal, okay. Yes, no history of PCOS, no nothing. So do you think what should I do in my prescription? Which drug should be the first one that I should use? Two patients I'm giving you. All right, one is a patient who has hirsutism and all these findings, and the hyperandrogenic state is there, okay, and other patient is normal, only like there is hair loss. So what is the best thing we can do? Both the prescriptions will be different, okay, if you know this point. What is that point? That if there is hyperandrogen condition, yes, we will give blockers, okay, right, the androgen receptor blockers we would give, okay. But if these conditions are not there, we will prefer minoxidil, we will not prefer this, okay. So I don't want you to remember, like, okay, fine, it is just because of the female, right, we will just give these, and for men we will give minoxidil. No, it is not like that. So we should assess the patient, only then we should be very clear about our prescriptions, okay. So that was about the treatment plan, right, for the males and females, okay. So for the males, we'll be using what? We'll be using minoxidil for both, okay, and we'll be offering finasteride, dutasteride for the males, okay. Then we can do PRP and hair transplantation. About the female, we have these androgen receptor blockers are there, okay, and we will give minoxidil as well, okay. And what to choose when, we just discussed that, okay, fine, if the female is having any conditions that she has any hyperandrogenic state, we will prefer the AR blockers, okay, over the minoxidil. If we don't see any symptom like this, we will give the minoxidil. That has a very good result. This one point is very clear to us. Now we'll go on to the diffuse pattern, okay. All right, now we'll go on to the diffuse pattern, what it is, what's not, we'll see about it. So there are only two conditions over here, yes, that is anagen effluvium and telogen effluvium. So effluvium was fall, right, we read in our classification, right. So effluvium means fall, okay. So the hairs which are in the anagen stage, they fall off, Yes, for some reason we will be discussing about it as well. So, but the point to be noted over here that these are not androgenic state. The androgens, it is not because of androgen. So the DHT and the whole story, this is not the story here. The story is something else. What is the story we will be reading? Okay, so are you clear about this? That okay, fine. It is not related to androgens. It is not related to the androgen receptor. No testosterone, this and that, everything. No. Okay. All right. So what it is? This is because of the anagen. Their phase there it is arrested. It is stopped, arrested in the anagen phase. Okay, because of what? Because of chemotherapy, radiotherapy. Right? They are arrested in the anagen state. Okay. Because of this arrest, what happens is the hairs are not able to move on and go to the next stage. Okay, that is the reason when there is commencement of the therapy, right, till hair falls after 2 to 4 weeks. This range is very important, right? Okay, this range is very important. So because of the hair fall, because of the hair is arrested, right, in one stage, so that is the reason 2 to 4 weeks hairs are lost. But the good part is when the offending agent is stopped, for example chemotherapy, for example radiotherapy, offending agent is stopped, what is going to happen is we will just have the hair will regrow. Okay, the hair will regrow, nothing to worry about. Definitely the density comes back. Okay, why the density comes back is because the stem cell is still present. Okay, because the stem cell is present, the whole hair follicle is grown back. Okay, now we'll read about the telogen effluvium. Okay, so over here what is the main reason is because the hairs are arrested in the telogen phase. Okay, so this was the ACT, the third one. Okay, the shortest stage which was there. But over here, yes, we discuss about the stress, right? The exam stress. This is the one I was talking to you before, like sudden severe stress is there. Okay, about the exams. In the exams, when we have sudden stress, this happens, and there's corticosteroids and everything, and the hair falls off. Okay, usually the hair fall is in this stage. It should be about 100 hair falls, right? But in this stage, what happens is there are about how much? There are about 100 to 1000 hairs. In this, okay, that it is quite suddenly it happens. Okay, all right, that is one thing we have to know. What are the other states that in this? What are the other states that we could have this condition, that is telogen effluvium? What are the other conditions? That is some severe trauma, right? Like after childbirth. Okay, after pregnancy, during childbirth. We could have this conditions could be there. Okay, what are the other conditions? Like that there are severe psychological stress. That could be one reason, right? And so that is the reason there is this dramatic hair fall. Okay, and there is this one other condition, right, that is called as, this is the acute presentation. And in the chronic telogen effluvium stage, what happens is because of probably if somebody is going under crash diet. Okay, somebody is going under crash diet, probably called as a watermelon diet. Okay, there are severe deficiencies. All right, there is malnutrition. Okay, and in some conditions, some metabolic disorders also we could have this. Yes, we could have this condition like SLE. Okay, all right, so just a few examples, right, about this. So these ones are the chronic ones. These are the chronic ones. Okay, okay, all right, so this is just about that. And yes, in this deficiency, right, so I just want you to remember one thing over here as well, that is the zinc deficiency. Like even in us, like we usually have this zinc deficiency a lot, so if we have zinc deficiency and we take up zinc, though the density of the hair increases quite a bit. So a lot of writing over here, but it's alright, it's fine. That is all about telogen effluvium. Okay, these are the few conditions that we should know about it. Okay, alright. So now let us see about 𝗏𝗏𝗵𝗵𝗺. Alright, so what is the main reason of having this is just the stress, right? Okay, so during the stressful period, it could be anything. Yeah, so what happens is, because of that, yes, the etiologies could be any. It could be as simple as exam, right? It could be as simple as, something catastrophic happening in our life, increase in surge in the corticosteroid levels, right? And the whole mayhem starts. We itself feel, right, that whenever we are stressed, we tend to shed a lot of hairs. Yes, suddenly we will do, but when we are happy, when the serotonin is spiking high, we won't really feel all these things, right? So yeah, so stress is related to this one, that is 𝗏𝗏𝗵𝗵𝗺. Okay, and yes, definitely I have mentioned some points as well, right? What are the acute and the chronic cases where we can see this? Okay, but just before that, what are the normal number of hairs that are that shed in a normal day? That is about 100 to 150 hairs. All right, so whenever we comb our hair, so we should not get stressed that oh my god, I'm losing this much hair, so what to do? Not to run towards the dermatologist, trichologist, to see. So because we should know these things, right? What are the normal numbers of hair that we lose every day? All right, so it is about 100 to 150 hairs. All right, but in this condition, what happens is we lose about 100 to 1000 hairs daily. All right, so that is a lot. Yes, that is a lot to at least if this goes for, I guess, 6 months, 1 year, the density is less. All right, so and even after a year, we see that, oh my god, there's so much difference in it. In case we don't see the difference down the line, then after some time we see that yes, the density is gone, right? But yeah, we can work on it. That is the reason, yes, so we should not take much stress, but this is just to be said, right? But still, we can definitely manage a diet, we can manage our lifestyle, yes, and not to be in one room all the time, and go out, have a life, play, and have that dopamine surge, right, day-to-day basis. So the stress part is managed quite a bit. All right, so first of all, we have the acute and the chronic causes. Okay, acute causes could be as simple as childbirth, yes, severe psychological stress that all the doctors face every day. Yes, so this is like a normal part of our life. Okay, and this is the reason there's like dramatic hair fall, like sudden hair fall. Like we said, like yesterday everything was okay. Like last week everything was okay. Now I'm having a lot of hair fall. What's up? So this is these are the kind of patients. We need to, yes, definitely we have to give the treatment, but more than the treatment, we have to consult the patient. We have to give a proper counseling to the patient. Right? Please tell me what is happening in your life. What, like we should do a proper family counseling of that patient. What we should know the reason why the patient is in such state, right? So this whole spectrum of the consultation comes under family physician, right? So that is one thing which they take care of. Okay, chronic state, it could be as simple crash diet. Yes, the watermelon diet which is there. Yes, crash diet, and what is happening over here is a lot of hair because suddenly, because the person was not going gradually into a caloric deficit state, right? So the person suddenly got motivated looking at some video, and then they just decided that okay, fine, we just follow it, and the body was not habituated to that less food. So that is a stress factor for a body, that is a trigger factor for a body, that oh my god, so what just happened? Alright, so that is one thing about the crash diet. Severe deficiency, that is zinc. See, in severe deficiency, yes, and even in that there is zinc in our diet. If we maintain zinc 100%, this thing can go in our favor than in opposing it, right? We can have a good density of hair, we can have that long luscious hair, right, if we maintain zinc. And zinc is found in bajra, right? I don't recall the English name for it. Yes, it is called bajra, and that has to be in diet or in any form of manner. We should have that. And metabolic disorders also cause it, that is SLE, because it is causing a stress with the body, right? And in this, and I guess we could understand that in metabolic disorders, right, there is a lot of thing happening in the body at one time. Yes, so the patient is pretty sure not that comfortable, right? So that is one of the reasons. So that is about the 𝗏𝗏𝗵𝗵𝗺. Fine. So now we'll go on to the next part. Okay, so let us just go back to our classification. We'll see where we are standing right now, and then I'll continue this lecture. So this is the part, right, where we just started the whole chapter, right? The alopecia. So this is about the cicatrial part. This is non-cicatrial part. That is the scarring and non-scarring one. Do you guys remember what it was? It was just about inflammation, right? Inflammation is seen in scarring. Okay, and in no non-scarring, there is no inflammation. Okay, so the whole discussion till now, all the discussion was about this. We took a pattern one, we took a patch, we took a diffuse, we took all of this is done. Alright, so now we are going on to this part, that is the cicatricial part, the scarring part. Okay, alright. There are specific topic in this. Okay, as such this topic could be very elaborative, but I have included some part of it. Okay, and just made like a detailed, concise version of it. Alright, so that is that. And let us just continue with the cicatricial one. Okay, and in this there are a lot of topics which we have already done, so this will be a revision for you and me as well. Alright, down the line. So let us get started with the cicatricial alopecia. Alright, so now we have it, cicatricial alopecia, that is the scarring alopecia, right? So what is going to happen is the stem cell, I hope you guys remember the bulge, yes, which was there, right? The stem cell, that is the one which is affected, right, over here. If that thing is gone, the stem cell is gone, do you think the hair is gonna grow back? 100% no, right? So if a patient comes to you, so should you give him or her false hope that okay fine, everything will be okay? You cannot give, right? Because we know the etiology. Okay, that is one point, a practical correlation point that we need to focus on. Alright, fine. So let us get on the details, right? So first of all, we have the primary cicatricial alopecia and we have the secondary one. Okay, alright. Primary is very simple, that it is just classified on the base of etiology. Okay, in primary cicatricial alopecia, what happens is the hair follicle is destroyed by inflammation. Alright, and in the other one, it is by certain traumas. Any trauma it could be. Primary is inflammation. That is the main thing we have to remember. Alright, real quick, and then we can go on to the next one. That is follicle is destroyed by inflammation. And inflammation, we did this, right? And there will be inflammation, there will be scarring. Okay, will there be pus or not? Yes, right, there will be pus. Okay, alright, follicle is destroyed by inflammation. And in the secondary in the secondary cicatricial alopecia, right? So just a few points that I have written, that yes, there could be burns, trauma, and there could be also severe psoriasis. Alright, one thing over here that I wanted to write is also because of infection. Boggy swelling. What was that boggy swelling? You know, we spoke about so detail in the bacterial infections. What was that? It was 𝗘𝗏𝗏, right? 𝗘𝗏𝗏. Fine. So I hope you're getting that image in your mind. Yes. So we also have in a couple of pages we will be seeing we will be meeting 𝗘𝗏𝗏 again. But until then, right? So we just write it up. That is, it could be because of inflammation. That is a 𝗘𝗏𝗏. Alright, so we just got done with a little bit of introduction, right? That is the primary and the secondary one. Okay, so let us just go for the clinical feature, right? So these would be pretty vague. These could be pretty vague. Yes, why? Because you will see, right? You will see why it is such a presentation. Alright, so first of all, we have this one, that is it is very smooth, shiny scalp with no follicular openings. Alright, no follicular opening. Alright, that is one thing. Yeah, we need to remember. Okay, so the skin, right? The skin over the scar would be very smooth. Yes, and there will be no, like this one. Alright, right here you can see. Okay, fine, you got it. If you see this image very carefully, so it just a very smooth shiny skin, the follicles are all closed up. Alright, fine. Okay, so now we have the patch size, which is increasing gradually. Yes, because of certain etiologies, right? Could be this is because of the LPP. In LPP, right? So what is happening is it is because it is an autoimmune condition. If the immune system reaction, right, it increases in strength. So what is happening is definitely the LPP, the size would be enlarged slowly and slowly, right? As simple as that. Okay, so patch size increase gradually, itching and burning sensation. Yes, okay, definitely this is a very vague finding, just like 𝗃𝗃𝗃𝗃 conjunctivitis. Okay, alright, so we have nausea, vomiting, so over here there is itching, burning sensation which is there. Okay, fine. Jokes apart, what is a very key hallmark finding that we find? This is the one, right? That is the perifollicular erythemas. Okay, right here you can see the perifollicular erythemas. Okay, and scales. Fine, so we have it. So I just try to include a bunch of images here, right? So each of these images do represent a certain chapter. All right, so it is that. But over here I just want you to have like an idea, right, about how the things are. So you can see over here there is this scar formation, and I just want you to focus on this part, right? You see this perifollicular, extravasation, right? Over here we have these hemorrhages. Over here, who you see, and in all of this you cannot see any of them, right, which has a follicle which is open. All are closed. Yes, you see this shiny, flat, it has a very clear base. Right here as well we see the sign, okay, and from here the hair is going to break. Alright, so now let us see the first example, right? That is the LPP, that is lichen planopilaris. Okay, so this is a lymphocytic pattern. Alright, and in this we only have to remember a few things. Okay, so first of all, this is an association with the classical lichen planus. Alright, and there are other association as well, but we just need to remember this one. Okay, and in this there is a very particular triad, right, that has been followed. The first of all, this is the first of all we have the perifollicular scaling, right? We just over here you see, okay, that is the first one. How about the next one? This is, you can see the violaceous discoloration. Alright, so this is a very particular thing about lichen planus, right? This purple flat top polygonal shape, yes, pruritic lesions. Yes, we see when we read the chapter about whole lichen planus, we read about this. Yes, so you can see over here as well. I'm not telling that this is lichen planus, this is LPP, okay, and over here we have the scarring patch. Alright, so if we just remember this, a very small topic, right, about the LPP, that is lichen planopilaris. Okay, so this is the one, okay, which has an association with LPP, with lichen planus. How would you treat it? Definitely we only have a few things, right? We can either control the immunity or we can just control the abuse, right? So over here we can give the patient topical interlesion steroids. Tetracycline could be given, and JAK inhibitors. Over here, just about this topic, right, LPP, if we just remember this triad, let's go on to the next one, that is DLE. Okay, discoid lupus erythematosus. Okay, so when first time when I read this topic, right, okay, I was just confused between SLE and DLE. Alright, so over here, before starting this, what I'm gonna do is we will talk a little bit about the discussion, little bit about the confusion part. Okay, so whenever you see DLE, you just remember that this is about dermatology. Okay, dermatology. So I want to have this link in the clinical features as well. That is the reason I'm taking this counterpart first. So if we write DLE, that D is for derma. Okay, all right. But over here you see, yes, in DLE over here, this is just a way to remember and not get confused. D means discoid, it doesn't mean derma. Okay, this is just a little bit mnemonic that I want to give you, that so that we don't fall in the pits, right, about the naming part. Okay, about SLE? SLE we all know, right? It has a very extensive, yes, systemic involvement. This is systemic involvement. Alright, so now let us just go ahead and see about DLE. Okay, so first of all, what did we read here? That it is about dermatology. Okay, so the thing we need to remember about this is that it only involves the skin part. Alright, fine. It does not involve the organs. Only the derma part is involved. Okay, the face, scalp will be involved, but not the organs. Okay, that is one thing we need to remember, that first of all, this is not SLE. And over here there will be skin involvement. Okay, all right, that is one thing that we have to remember. Okay, and over here I just want to add one more point, that the SLE, right, in SLE we could see DLE. Yes, okay, this one point I had to add here, that so that this could be an extension to this. Yes, but this and these DLE and SLE are separate entities. Okay, fine. Okay, so where do we see this? Is in the photosensitive areas. That is the first place. Okay, we see in the photosensitive areas, as you can see in this image as well. You see right here. Yeah, this is the part where sun exposed part. Okay, alright. How about the next point, that is we have follicular plugging is there, and in them we will find depigmentation and scarring will be there. Okay, and it is a very classical word over here, that is carpet sign. Carpet sign. Alright, so the carpet sign is a very classical feature of it, that when the keratin plugs are removed, yes, that is when we see this. Okay, that is when this sort of structure is formed. Okay, alright, so we have a few more images over here as well. You can see this is the sun exposed part, sun exposed, right? And over here you see on the scalp as well. Okay, alright, and how about the treatment? What do we do about the treatment? So first of all, we have to protect the skin. Okay, that is a mainstay of it. Okay, that is just the skin protection. And how would we do skin protection? Definitely we can cover it off, and we can also use some sunscreen, right? Sun protection is the mainstay. Hydroxychloroquine and systemic steroids could also be given. Hydroxychloroquine and systemic steroids. Okay, you got it. That is all about DLE, right? So very small topic, yes, nothing much in that, but if we just remember these 2-3 things, we will never go wrong in this. Okay, fine. Next up we have linear morphia. Okay, over here we have linear morphia. All right, so let us start with that. That is linear morphia. And over here I just want to tell you one point, and everything will be taken care of. So you guys must have read about scleroderma. All right, in scleroderma what happens is a particular molecule is been deposited to a lot of places in our body. Yes, that is the reason the whole mayhem occurs. Which molecule, yes, which type is deposited in which organ, it is such a extensive list about it. Okay, but over here what is happening is that at only one spot there is the features of scleroderma. Okay, did you get it? I'll repeat once again that in this, what is in linear morphia, what's happening is there are features of scleroderma at only one spot. Okay, that is what it is. All right, and there is no organ involvement, only the dermis is involved, that is all. Okay, and it could happen anywhere, happen in the hands, legs, and it could happen anywhere. But if it happens on the scalp, on the face area, on the scalp, we have a specific name for it. We'll see about that. Okay, fine. So we have the introduction about that, and we see linear morphia. Morphia means it is localized. Okay, at one spot. It involves skin and sometimes the underlying tissue, but it does not involve internal organs, right? Unlike systemic sclerosis. Systemic sclerosis, everything has a big thing to it, right? But this is only limited to the skin. That is it. Okay, alright, so linear morphia. It follows Blaschko's line, yes. And what are the special types of it? That is, first of all, this is the one I was talking to you about, that if we have it on the scalp, right? We have, where do we have it? We have it linear morphia on the scalp. And what is this called as? Is called as 𝗵𝗵𝗵𝗵. Alright, so I hope I'm getting that right, but if I'm getting that wrong, the pronunciation, I'm sorry for that. Okay, cool. So how do we see these images, right? We see right here, yes, it's just like a sword, right? It's a sword sign. Okay, right here you see, yes, there's such a loss of hair, right? There's so much scarring in it. Okay, alright, so that was about it. Yeah, so now let us go on to the next topic. So now let us talk about tinea capitis, right? This is one of the topic we went so extensive about. Yes, and yeah, this is the cause of cicatricial alopecia, right? The inflammatory one. Okay, even in this we saw two different types. If you guys remember, we draw. There was a whole differentiation page, right? Okay, and what I've done is I've also included that in our notes right here. So what's going to happen is we will just go back and do like a quick revision. Yes, and come to the same topic as well. But first, let us just see some points regarding this topic. All right, so these are the same notes, yes, that we did before. Okay, all right, so nothing different in that. Fine. So what is it? This is the inflammation of scalp hair shaft. All right, so it is rare in adults and most commonly seen in children. Yes, and there are two different types as we spoke. This is a non-inflammatory and inflammatory one. Okay, so the inflammatory one is the topic which is concerned to us because we are reading cicatricial alopecia. All right, this much is clear to you. Okay, and in this, if you guys remember, we did two types, right, of the presentation. So in this, right, the nature of fungal spores, either it could be endothrix or either it could be ectothrix. Okay, in endothrix it was inside, yes, ectothrix it was outside. Okay, fine. So let us just let us just write that real quick. In fungal spores, in ectothrix it is inside. and over here it is outside. Okay, so one question to you, because we have already done this topic. So if in ectotherics, right, the first one, if in endotherix, yes, the spores are inside the hair. Okay, so what's going to happen is, if there are too many fungal spores, right, in the shaft of the hair, what's going to happen? The hair is going to break, right? The hair is going to break. The hair is going to break right at the shaft. Yes, and you will see the black dot sign. Yes, this is what we read. Okay, so it's coming up, the whole revision page is coming up. Yes, so this is one correlation that I wanted you guys to remember. All right, so this is what I'm talking about. Yes, this is a page number 101 from our notes in the same PDF, the one which you have. Okay, all right, so let us just take this opportunity and do a quick revision of this. Okay, but before this, let us revise the mnemonic. Okay, what was the mnemonic? It was this. Okay, in this, the whole chapter, yes, we know the ectotherics, endotherix, everything we know, but what is more important is to know the causative organisms. Yes, for that we gave a mnemonic. All right, what was it? TV is seen in the house. Obviously, TV, we cannot see TV on the roadside, right? TV is seen in the house. So TV was Trichophyton, Violaceum, and Tonsularis. Yes, in the what? It means endotherix. Okay, in the, right? TV, TV, TV. All right, you got it. TV, fine. Endotherix, in the house. Okay, and how about the ectotherix one? Yeah, we read about, we saw this one. Gray cats are furry. Gray cats are furry, right? So gray cats, it means the gray patch we saw, right? The gray patch, we'll see the image as well over here. The gray patch are furry. Microsporum ferruginosum. Cats was canis, and over here, because we say gray cats are furry, that is why it is ectotherix. Okay, all right, that is the opposite of the TV seen in the house. All right, fine, this much is clear. If we remember these two sentences, so we will never go wrong regarding the example part, which is the point that we have to remember. We cannot compromise in that. Okay, all right, let us just go on, and let me go through this real quick. That is this one. That is this one. That is a non-scarring alopecia, and this is scarring alopecia. Non-scarring alopecia is caused by TV, right? Trichophyton Violaceum and Trichophyton tonsularis. Okay, that is the one. And we see this was the one I was talking about, right? This is the concept we just discussed. All right, so these are the multiple black dots that we see. Okay, why is the reason? Because of the nature of the fungus, right? Because of the nature of the spore of the fungus, we see this finding. So there is a clinical correlation behind the nature of the fungus, of the nature of the spore. All right, this is the important point that you have to remember. Okay, all right, go on to the next one. The gray patch is because of ectotherix. Yes, ectotherix is outside. Okay, that is the reason we see something like this. Will we see the black dot sign? No. Okay, why? Because of the nature of the fungal spore. All right, fine, this much is good. Cool. So who is causing it? Ferruginosum and canis. Okay, the gray cats. Yes, this is the example for it. Okay, the inflammatory one, yes, this is the scarring alopecia that we have. This is the topic of our discussion. Yes, as pertaining to the disorders of the appendages. Scarring alopecia, who is causing it? Tinea mentegrophytes and Tinea verrucosum, Microsporum canis. These are the ones who are causing it. Okay, Kerion, the boggy swelling. Yes, we all remember that. What do we see? We see these multiple sinus discharges, right? Yes, there is positive for inflammation, positive for sinuses, and positive for scarring. Yes, a very good example to remember this topic. You remember this one topic, the whole scarring alopecia is done. Okay, this is how I remember. Next up is FMGE, right? FMGE is endotherix with hair spaces inside them. Okay, you see this Tinea Schonleini. Yes, you see this. All right. This is a very pretty popular image, right? We see common everywhere. Okay, fine. So over here, what do we have is concave yellow cup-shaped webs called cutula, right, on the scalp. Right, you can see almost just like a cap. Okay, that is what we already discussed about these things. Okay, so that was a quick overview about it, and I've included the treatment aspect as well. Pause. Continue. I have included the treatment aspect as well. That is what I am going to give for the Microsporum species. Oral glisophulvin is gives a very good result to this, and Trichophyton species, that is oral terbinafine, right? We give this, and what is the mechanism of action? It inhibits the 𝗲𝗵𝗿𝗺 epoxidase. All right, this is one thing we have to remember. Okay, so it was a very quick revision about this topic as well. So now let us come back to the topic. Over here we have the end stage of the whole scarring thing. Okay, whole alopecia, I think this is the end stage. This is what it's called as scarring alopecia, that 𝗲𝗲𝗹𝗵𝗺. This is the name, and over here this is the end stage, final stage of it. All right, so let me just write that down. Over here we can see this topic is important because of this one word, that is footprint in snow appearance. Okay, this is here, these are the footprints, you see, the as such these footprints. Okay, fine, definitely get this the snow appearance, right? It has a lot of it, but definitely looking at the first snow, probably it snows in the night time, and you open the window and it's like that pristine white snow, and for some reason the snow is so radiating, right? And to see that, and probably in the morning have a cup of coffee, just the perfect moment in our life. All right, fine. So holding on to that and coming back to the topic, and in histopathology, all right, so we find this perifollicular concentric fibrosis is seen. Now the whole hair part is completed. Yes, now we'll go to nail. Okay, the hair part is all completed, all done, and I hope the discussion was good. And if you do this much, we have completed a lot. Yes, with this, and in depth we have gone and we saw each and every topic. All right, so now I'll start up with the nail, and in the nail, first up we'll see about the anatomy. The nail anatomy is very important, and after that we'll see the infections and the disorders about color, right? That is one thing we will cover about. Okay, and the metabolic disorders are also there. Yes, the Perry's nail, Mees lines, Blues lines, everything is coming up the lecture. All right, so fine, let us just start with the nail topic, the nail. So first of all, the nail matrix. Okay, this is one thing, we would just start with the nail matrix. Yes, what does nail matrix produce? We produce nail plate. Simple, right? Nothing much complicated. Okay, fine. Over here we have this relation over here that we have to remember, that is the proximal part, yes, provides the upper dorsal one, and the distal part provides the lower ventral part. Okay, and the proximal part is the one which protects the nail matrix. Okay, all right, this all will make sense once we are done with the diagram. Yes, over here we have this diagram, you can see this is the structure of the nail. Yes, over here we just go with the gross appearance first. Okay, so over here you can see a normal nail, a very healthy nail, right? So this part, you see, this is the nail plate, and over here you see this is called as a cuticle. This is a very layman term, cuticle. We'll see what the other name for it, but I just want to have that orientation correct now. What is it? It is a cuticle, and we have over here we have the proximal nail fold. Over here we have the distal nail fold. Over here there is lateral nail fold. Okay, simple. You got that orientation right? Okay, simple about the nail anatomy. Now let us go on to let us just go straight up, see this diagram. Okay, and then we'll see the other one. Now let us continue about we see this diagram first. All right, over here we have the nail matrix. Okay, nail matrix is there, and this is the one who is giving out the nail plate. Okay, and over here you see, what do you see over here? Yes, it is in the structure. There is if you see in your fingers, right, there is this crescent shaped thing you see over here. What is that? Yes, this is called as a lunula. All right, lunula. This is called as a lunula. Let me just write that. Okay, all right, this is the one. And over here you see this because of the lunar, right, the name we have it, right, the half crescent shape, crescent moon shape structure we have. Okay, that is the one. Over here now we have the cuticle. Now you see this was the one, right? This was cuticle here. This is the cuticle here, is all is called as eponychium. All right, we have these 3 nychiums. Yes, and the infections will be the same. Over here you see this nychiums, right? There are three of them, right? This is the peronychium, eponychium, and hyponychium. All right, so what's important is to know the location of it. Okay, so we just start with the cuticle, that is eponychium, that it was right here. All right, and over here you see this is the nail plate, and at the very bottom we have the hyponychium. All right, and there's one more, that is the paronychium. Where is it? It is at the lateral borders. Yes, this right here, right, when the nail plate is inserting inside, this is this part I'm talking about. Okay, that is the paronychium. Okay, all right, fine. We have these three parts are covered. Okay, and over here we see the nail bed which continues on to the hyponychium. Okay, these are the few words that we have to know about the nail anatomy. Okay, and all the findings, right, there could be either problem in the nail plate or either there could be problem in the nail matrix. Two things that we have to remember properly, either nail plate or either nail matrix. Fine. One more diagram we have over here, that is about the free edges in the extra hair, the extra nail that we have, right. This is the nail plate, the very bottom one. This is the lunula, right, this crescent appearance you see, right, this is the lunula. Right here we have the cuticle, right, the eponychium, the cuticle which is there. Okay, what is that, what is over here? This is the cuticle, eponychium, and what is at the distal part? It is hyponychium. Okay, even though in this diagram you cannot see it very clearly, but if you just add the three diagrams together, this and this and this, then you will have a proper imagination, right, that where is the problem, where is this exact structure. Okay, all right, these are the nail grooves and nail bed. Okay, and these are the nail walls and matrix which is there. The nail bed, in the nail bed, what is happening is, because of the lunula, yes, we see the, what is happening is, because of this there is a compression toward to the blood vessels. Okay, the nail bed is a part where all the blood supply is, right. If you see this, if you see in our nails, right, so we see this, if we just press it up, and over here if we press it, there is a part which goes completely white, but there is a part which still has it. Yes, okay, fine. Okay, so that is all about it. Let me just make a quick revision over here as well, right, over here. Why? Because I want you to know the vocabulary about this part, because usually we don't go into this much depth, right, when we read about it, because we think that okay, fine, we just know about a few things and then we are good to go, right. But let us just go ahead and see this one more time, that okay, fine, we have this is the nail, right, this is the nail, a healthy nail. This is the nail plate, cuticle. What is cuticle? Eponychium. What is cuticle? Eponychium. What is the distal part of the eponychium? This is the hyponychium. All right. And what are the lateral part? These are the paronychium. All right. These three nychium you have to know very well. Okay. If you read it once, I don't think so. It's like a very complicated thing. It is just that, did we read this or not? It is just that. All right. Over here we have the nail matrix. Nail matrix extends to form what? Cuticle? No, right? Nail matrix is the one who's forming the nail plate. Okay, if the nail matrix has some issue with it, any sort of XYZ issue, do you think this will be formed properly? No, right? So it won't be formed. There will be some sort of changes in it. Either it could be wavy, either that could be like there could be certain line to it, and there are a lot of different presentations in it. So these are the two mainstays, right, for the whole thing. Okay, all right, fine. So now let us just start with the nail disorders. First of all, we have the onychomycosis. Onychomycosis. So this is not a new topic for us. All right, absolutely not a new topic for us. Why? Because we read the whole thing as when we were doing our infections chapter. Okay, all right. So these are the same notes, and I just want to take this opportunity again to revise the whole thing. We will do everything just as we did it first time. Okay, so what are the two causes? Yes, these are the causative organisms. That is, it could be dermatophytes and it could be Candida infection, right? And in this we had four types: DLSO, PSO, WSO, and TDO, right? And we saw everything about it. Yes, so let's see about the first one. That is a distal lateral subungual onychomycosis. Distal lateral subungual onychomycosis. Over here you see just wonderful diagram, right, and just try to correlate with this. Yes, you see this part is involved. Okay, all right. And in the, how about the PSO, the proximal subungual onychomycosis? So if you guys still are confused, right, about the proximal distal part, so distal is the 𝗲𝗏. Yes, the further one. Okay, distal is 𝗲𝗏, and proximal is the one which is near to the central. Okay, in case you guys mess that up. So this is the PSO part. Okay, alright. We see, will we see in a normal individual? No, this is most common in HIV patients. How about the superficial white onychomycosis? You see these flakes, right? These flakes, as you can see, right? And if we try to scrape it off, what do you think? Will they be very adherent, or they will easily give off? They would. What would happen? They would easily give it off, right? It is scaly, and if we can easily scrape it off. Okay, and even in mouth, yes, when we were reading it, what were the two lesions which had the similar sort of things? What was it? Yes, oral leukoplakia. In that, the lesions, could they be easily scraped off or not? Not, right? In oral candidiasis we could do that, but not in the oral leukoplakia. Okay, we read about the whole thing. It's just a association with that, so I just thought of mentioning it here. Okay, fine. We go on to the next topic, that is the TDO, that is total dystrophic onychomycosis. TDO. Okay, absolutely, you can see this. The nail bed is gone, the matrix is gone, almost everything is gone. Okay, all right, nothing much to do here. Fine, this complete destruction of nail. Fine. What would be the treatment in case this is not here? If it is this, what would be the treatment option, right? So if you guys remember, we were using nail lacquers, right? Nail lacquers. Yeah, this is just like the nail paint. This is just like the nail paint. Nail lacquers we apply how many times? This is a revision. Yes, this is a revision. Nothing is new. The notes are also the same that we used before. Okay, the same. Everything is the same. Yes, how? Let me give you some options. Once in a week, once in a day, once in a week, or once in a month. All right. So what is it? The answer is once in a week, right? Okay. Fine. That is something. Okay, you got it. And what was the name of the drug? Yes, amrolfin. Yes, amrolfin was it. It was. Okay. Cool. So we just go on and write our notes as well. That is nail lacquers, and they work very wonderful. Why? Because the drug is structured so that it stays on the nail. There is continuously action of the drug we can have because of this. Just imagine if it was just a topical cream. We could just wipe it off, right? So we just, like, probably in 10 minutes or so the patient is doing something and it is just gone. So the continuous action is achieved because of this, the nature of the drug. Okay, these are the nail lacquers. Okay, that is weekly. Okay, and we can also give cyclopyroxamine, which is daily. Cyclopyroxamine lotion, that is daily. Okay, luliconazole can also be given. Fine, but the mainstay for this is the good result, very good result. Okay, fine. So now we are done with that. Now we'll go on to the pittings, the nail pittings which are there. We read about this before as well, but now I'll just add up all the disease which has these pitting findings in them. Okay, and you just read these notes, have a good listen to the lecture, and this pitting topic will be closed once and for all. Let us begin. Okay, all right. As I mentioned before, the problem could be two places, either the nail plate or the nail matrix. Okay, in the nail matrix we have, if there is defect in nail matrix, it could be pitting, right? Okay, fine. You please have this the orientation should be very clear, right? So this is the reason we should know this part very well. Okay, I repeated it 2 to 3 times. Fine, this is the part, the nail matrix and the nail plate. Okay, fine. Okay, we go on to our discussion. In psoriasis, yes, we saw this, right? So the P, right, in psoriasis, when you're making a mnemonic, P was about the nail pitting. Yes, and what is the nature of it? Come on, tell me. Irregular, random, and deep. Okay, this is not new. Okay, we read this before, but still we should know this part. Yes, properly, because we covered the whole psoriasis in very great detail. Psoriasis, this is irregular, random, and deep. Okay, fine. How about the alopecia areata? Alopecia areata, right? The topic we just finished. Yes, we just got done with this and we started this chapter. Okay, What it is a geometrical pattern, a geometrical pattern. What kind of geometry do we see in this? We'll see about that. Geometrical pattern is seen. All right, fine. What is this geometry? This is about these horizontal lines, as you can see. Definitely this image is not that clear, but yes, if you see from this point, you can elicit that there are some horizontal line formed because of the pits. Okay, all right, that much is clearly visible in it. Okay, how about the eczema? In eczema, what do you find? Yes, irregular mild localized finding would be there. Okay, all right, we have these two presentations. Even though the nail findings, yes, these pits and nail findings would not be seen in all of the patients, but yes, if they are seen, they have this sort of presentation. Okay, and how about the trichonychia? What does this word mean? I just mentioned this because I wanted to the vocabulary, right? What is it? It is about the 20 nail dystrophy, right? Okay, so we have psoriasis and eczema example of this 20 nail dystrophy. Fine. All right, so we have the 20 nail dystrophy, right? How about the pterygium? The pits are done, all done, completed. Okay, so you can just revise this page for the pits, and it's all good. If you, in case you find some MCQs or some more points regarding it, you can definitely add on to the sides. Okay, we have the pterygium. What is pterygium and what is the classical hallmark finding of which disease? Okay, all right, pterygium, right? So when we were doing it, we also had we completely covered these topics in such a great detail over there as well. Okay, fine. So about what this is, most classical feature, right? About nail lichen planus, right? Okay, nail lichen planus. This is pterygium. That is the most classical feature of the nail lichen planus. Okay, all right. What is actually happening, right? This is what it is. Yes, so you can see that the proximal part is just being fused, right, with the proximal nail bed. Okay, as you can see, the fusion of the proximal nail fold fuses with the proximal nail bed. All right, as you can see in this image is pretty clear about this. Okay, this is normal one. Okay, all right, that is all about pterygium. Now let us continue about the fourth one. All right, that is the blues lines. Okay, so what are these blues lines? Yes, so we just the image first. This is the first thing we see. How would you describe the image? Tell me first thing. Yes, these are the horizontal lines, yes, which you can see, and it is pretty clear, these horizontal white lines that you see. Okay, these are the blues lines, the horizontal depressions. All right, depressions over the nail plate that we see. Okay, what is because of what? It is because of the positions of the nail matrix. Okay, this is the problem of the nail matrix, not the nail plate. Okay, all right, what could be the reason of it? Tell me, what could be the reason? It could be due to severe medical illness. Yes, it could be due to chemotherapy. So one example is I want to give over here. When I was in my high school period, right? Okay, my dad, he showed me one patient. Over there, his toenail, it had these blues lines were there. Okay, I didn't know anything about it. What are these lines? This, that. I read nothing. Okay, but he told me, he just wanted to explain me, like, okay, what actually could have happened. Yes, in the patient's nail, yes, he told me, like, do you think this is normal or not? He asked me this first question. I like, no, this is not normal. And he told me what could be the reason, yes, for it. He told me, like, I told him maybe he just hit his bed or something, you know, some stupid reason I gave. Okay, but then obviously the explanation for that was wrong, and then he explained me that why this happened. Do you think that the nail grows like super fast, you know, like maybe in a day we can just change the nail? It is very slow process, right? It is very slow process. Okay, but he showed me, like, for example, this is almost the same photo as of the patient. I can still remember, but he was showing me the finding. My dad was showing me the findings in the toe, in the great toe. Okay, And in this, when he told me like, Mohit, see, when this nail was here, right, at that time he might have had some illness. Now he is okay, like this is the okay period. But when this part was here, right, because of the nail matrix, it is fusing with the nail plate and it is growing it, right? Yes. And as it goes ahead, the speed decreases. Over here you see, he told me like, when he was sick at this time, but now he is okay, but he was sick at this time. That is the reason of forming this blues line, right? And that time I was so amazed, like, wow, this is so interesting. Yes, I need to become a doctor. On that day I was just in high school, right, and just doing all those things, but definitely I thought like, definitely we have to become doctor. And this is so interesting, when two things add up, 1 plus 1 is 2, and yeah, this is just one of my personal experience that I had to share. So I hope with these small stories, it would be very easy, right, for us to remember these topics. That is the blues lines. Okay, all right, that is it. The horizontal depressions over the nail plate, and it is also pretty interesting, right? It is so intuitive. What now it is okay, like now the nail is okay, but earlier what it was. This is just like going into the past records and just seeing, all the old archives. Okay, fine, cool. Leukonychia, right? Over here we have true leukonychia. Yes, what is defined by true leukonychia, right? The problem is in the nail plate, and when you press, right, over these lesions, they won't go away. They are non-blanching type. Okay, you got this point? These are the true leukonychia. Fine. Okay, white color does not disappear on pressure. All right, does not is the answer here. It does not disappear on pressure, and it grows out with the nail. Okay, you got it? Goes out with the nail, like this we have it. And what is the most common type? Punctate one, right? The one which you can see. So this is like a topic, and there are subtopics in it. This is just like a general thing that we are doing over here, so that you can get the common characteristics of the other ones. That is punctate leukonychia. Okay, punctate leukonychia, how would you define this? Is the small spots, right? Small spots on the nail. Simple. Small white spots on the nail. Do we have to worry or not? We'll see in a while, but for till then we just write our notes. That is small white spots. Okay, small white on the nail. Okay, fine. This is the most common type. Yes, could be it is because of minor trauma, manicures, and aggressive cleaning. All right, it is because of that. So do we have to worry about this condition? Not really. It's absolutely fine. It happens, sometimes unconsciously we hit up something. Yes, so what happens is these sort of findings are there. That is and I'm pretty sure who all are watching this, at some point of time we did find these findings in ourselves. All right, okay, now continue on to the next one. That is the striate leukonychia, right? Striate leukonychia, that is the one. Striate leukonychia. Yes, over here what do you see? Horizontal or transverse bands? We just see here, these are the transverse bands, right? Okay, okay, transverse white bands, fine, across the nail. These are the ones who's called as Mees lines. Yes, so we have a forensic correlation over here. Yes, Mees lines. Arsenic finding, arsenic poisoning, thallium, and could be because of chemotherapy. Arsenic, right? We read so much about arsenic in the forensic, because if it is arsenic poisoning in a very prolonged period, we could have these findings. Yes, and arsenic is also found when we do the post-mortem. Yes, of an individual after a long time. We could still find arsenic in the body. Yes, this is a sort of diagnostic thing. Yes, in it. Okay, we have the Mees lines over here. Yes, this is very important that we have to remember. Okay, how about the next one? This is the leukonychia totalis. Okay, the entire nail is covered. Yes, in it, it is just as much as like, you know, somebody put a white nail paint on top. Yes, it is just as white as that. Yeah, too white. Yes, to be true. Okay, and what could be the possible causes? And usually what is what happens is, you know, so the nail findings, right, which are there, yes, we will be covering more, but still, whenever you have this abnormal nail findings, either two things could come in your mind. The etiology could either be the nail, either could be the kidney function, right? Definitely we can come to and by eliminating we can come to the answer as well. Yes, these are just the findings we see probably in some metabolic disorder, or in a chronic renal failure, or in a late stage of liver failure as well. Okay, alright, in the liver cirrhosis it also seen. We have the severe liver disease and hypoalbuminemia. The nephrotic syndromes, yes, the nephrotic syndromes are so important. Yes, in nephrotic syndrome, let me ask you a few questions over here. In nephrotic syndrome, what is a very key finding, you know, in it? What we would see? Nephrotic syndrome is edema, right? Edema we would see. And how about the nephritic blood? Yes, blood we will see. Yes, blood findings would be there. Nephrotic O, I just remember, like, whenever I see this nephrotic O, I just edema. Okay, fine. I see edema in pedal edema in patients somewhere in the question. Okay, fine. This is gonna be the one. Okay, definitely the medicine has such a great, you know, details and integrity, and everything is so interesting. Okay, so this is just one correlations over here, nothing much. You go to the next one. Yes, that is a mucous band. Okay, how would you describe this image? We just come to that. Mucous band. Yes, so this is definitely not a nail art. Okay, this is the nail finding. This is not nail art. Okay, how would you define this? Alternate bands, right? This is the bands like structure you see. Okay, fine. These are paired alternate bands. Alright, we have this. Okay, paired alternate bands. Fine. What do we see? What are the associations? Same as before, same as above. This is a hypoalbuminemia. Okay, this is the one. How about the next one? Yes, we have the Lindsay's nail. Okay, so definitely not the other Lindsay. Yes, this is the Lindsay nail. Okay, alright. Yes. Over here, the findings are pretty interesting. Yes, it is just like half and half thing, 50-50%. So what is this 50-50% thing, right? So you see over here, yes. What do you see? Proximal or distal? What are the findings? How could you define this image? Tell me. How would you tell me? What is this? The proximal white. Yes, proximal is the white one. Yes, and how about distant one? Distant one is brown. Yes, you see these are the white. Yes, this is the distal part. Yes, and if you see it more, white, brown. Okay, 50-50%. Simple. Okay, nothing much in it. Lindsay's nail. Okay, all right. That is very important that we remember this. Okay, what are the relations to it? That is, these are associations with the CRF, chronic renal failure. Okay, chronic renal failure. Nail findings. Whenever we see nail findings there, so just 2-3 points we have to remember. Definitely the Mees lines are there, but if you see these abnormal things, yes, 50-50%, you know, and the next is 90-10%, definitely there's something wrong with either the liver or the kidney. Okay, fine, that much we should know. Let me just highlight this point. Chronic renal failure. Okay, this is it. How about the next one? Yes, this is the Terry's nail, right? So over here you see this is the 90% and 10%. Okay, 90-10. So the proximal 90% of the nail is the one which is white, and there's a 10% band which is there. There's a 10% band which is there, that is brown. Okay, and this patient, you see, this image is from, it is not taken by me, but this patient is suffering from HCC. Yes, hepatocellular carcinoma. Okay, and these are the findings. Yes, you can read about the patient on the internet as well. Okay, I don't recall the exact name of the patient, but yeah, this patient has HCC and undergoing treatment. Alright, fine. So this is about the liver cirrhosis, and you see the proximal 90% of the nail is white, a distal 10% of the nail is brown or either pink. Yes, you could see 90% and 10% part, 90% 10% part. So that was all about Terry's nail, right? Okay, for the was 90-10%, and in Lindsay's nail we have 50-50%. Okay, and Talking about all the nails, right? So I had to cover the little bit of forensic medicine as well. Yes, so what we have here is something known as Burtonian line. Okay, Burtonian line. Okay, yes, over here we see, in which poisoning do we see Burtonian line? In lead poisoning, right? Yes, okay, in lead poisoning we see it. Okay, so it is lead PB poisoning. All right, so how I remember this one is, if we just write PB, right, PB, and if you just go like Burtonian line, because for me, I used to get confused so much in this is Aldrich-Mees lines, Burtonian lines. I was like, what is what is where, so I just wanted to dump everything at one spot. So this is it. Okay, fine, we have the Burtonian line. And what is the best way to remember is, if you just make it like this. Okay, all right, the PB, right, PB is the short form for the lead. Yes, so that is the toxicity about. Yes, so if we just do it like this, it becomes a Burtonian line. Simple. Okay, so that is one point I wanted to tell over here. All right, so that is all about the disorders of the appendages. Yes, so we went quite extensive about it. Yes, about the hair and nail aspect. Okay, so I hope this video was very fruitful to you, and definitely you might have got to learn a few more things from my side, right, as well. So thank you so much, and have a great day.